to spend some time talking about Chapter 1, and it talks about the HIT landscape and starts to kind of build a chronology, if you will. So in this unit, we'll talk about, kind of the landscapes impacting the United States. We'll talk about the different roles that the government initiatives, how the private sector plays into this, and how we've continued to advance HIT in the United States. And we'll kind of pick it up in the 90s. Clearly, a lot of things happened before then. Most notably, if you start with the 90s, two major things happened. The IOM, the Institute of Medicine, released a report that talked about kind of a call for HIT and some of the medical errors that were taking place due to handwriting, delays in moving data in the paper form. And then also HIPAA was established. But if you go back even before then, the two major players in the EHR marketplace still today, Cerner and Epic, both of those companies were founded in 1979 and had viable systems in early 1980. They were billing type systems. They didn't get a lot into the clinical stuff, but that's when it all kind of started. But the 90s is what really kind of jump-started this. What's important to note, I have people reach out to me all the time, some of my med students talking about how, their attendings, don't really seem to fully grasp HIPAA and, don't comply as well as they should. And what I tell them is, yeah, it's important to comply with HIPAA, but also try to, show a little bit of compassion because they are older than HIPAA. I grew up in a household where, my mom worked in the healthcare environment and it predated the 90s, it predated HIPAA. So it was perfectly commonplace and legal for her to come home at night and talk about patients that, had come into the hospital that we might have known. And those are kind of hard habits to break. So it wasn't until, the Clinton era that HIPAA came along and really started to establish some of that privacy, confidentiality, and security of our health data. Okay, the 2000s, so 2000 to 2010, that was when the High Tech Act came along. It was really towards the end of that in 2009. But that was the big kind of jump starter to really get hospitals to start to adopt technology. Then in 2010, when Obama gets into office, he puts into place the ACA, the Affordable Care Act. Also, some people refer to it simply as Obamacare. They are synonymous, one and the same. And then some other things, MACRA came along, which we're still trying to get there with. And then we're continuing to look at different payment programs as well. How do we structure payment and reimbursement for clinicians that both incentivizes quality of care, but also helps to foster a healthier patient population? Last, a bullet point on its own, something that we've been looking at and dealing with since the dawn of time is interoperability. How do we make these systems talk? So again, in 91, that was when the IOM released their report talking about, the call for computer-based patient records, which later became known as the EHR/EMR. Like I said, Clinton signed in HIPAA. HIPAA has, of course, undergone several evolutions. The fundamental problem with HIPAA was, of course, when HIPAA was drafted in the mid-90s, technology was clearly really still developing, and of course still is. It takes a long time to change HIPAA because it is a federal program. So the problem is, as technology evolves very aggressively, HIPAA doesn't evolve to keep pace with it. And that is and will continue to be the problem for a long time. So in the 2010 era, again, IOM comes back again and says 44,000 to 98,000 patients die each year due to medical records. Okay, so medical errors. And the report further went on to talk about how this number could be drastically reduced via the adoption of electronic health records. Now, so here you have a government, a federal entity that says, we've got all of these people dying annually due to medical errors, and further says, if you adopt technology, you can reduce this number. I'll never forget when this report came out. I was a entry-level tech guy at Cerner, And the CEO distributed a paper copy of the IOM report to every single employee at the company, over 10,000 of us, because it was that important. Because here you have a neutral party saying, hey, buy HIT software. And we were one of the biggest players in the game. So naturally, we saw sales and adoption of the Cerner system go up. Of course, other firms like Epic and, Meditech and GE did as well, but we definitely saw some good residual from this. In 2003, yet another attempt to try to bring Medicare up to speed, the Medicare Modernization Act. 2004, the Office of the National Coordinator, the ONC, which we'll talk about quite a bit in this class, was established. And then in 2009 was where we really got going, okay? The HITECH Act, and HITECH is an acronym for Health Information Technology for Economic and Clinical Health. And as I mentioned earlier, that was part of ARA, the American Reinvestment and Recovery Act, kind of spawned off of this under the George W. Bush administration, okay? Next, Obama comes into office and he signs several things, but most notably, one of the pieces of legislation Obama was most known for was the Affordable Care Act. Like all legislation, regardless of which kind of political camp you're in, the Affordable Care Act brought some very positive things into healthcare, and it also brought some things that didn't quite work out as planned. One of which was this thought of the marketplace where we would sell insurance to people that didn't have another mechanism to get it. And that was a result of part of the Affordable Care Act was a mandate that said everybody has to have insurance or you pay a penalty, a financial penalty. The thought was that we had a couple pockets of people that didn't have insurance, big pockets of people. One pocket was very young, people that maybe are freelance, young people, maybe right out of college that don't yet have an employer plan. And then some of your older population, maybe near retirement, that's retired early, not old enough to go on Medicare. And the thought was, just from a sheer statistics standpoint, the younger population doesn't need as much healthcare. The older population uses a significant amount of healthcare. And the thought was we could kind of cost shift here. We bring in both of these populations and it'll balance out the risk pool. What happened was a large portion of the older population joined. The younger population said, you know what, this is still too expensive. I'm just going to pay the penalty, and I'm not going to worry about it. Okay? So it created a problem. Some of the other things the ACA did that was beneficial was things like no lifetime limits on plans. If you had a major chronic condition, that could have been a problem prior to the ACA. The ability to stay on your parents' health insurance. A lot of undergraduate students benefited from that a great deal. And in fact, many were able to go all the way through grad school and still stay on a parent's plan, which is incredibly beneficial. In 2015, Medicare access and chip reauthorization, MACRA, if you will, again, looking at another way to do a better job with payment reform, reimbursement reform, all of those things. Still working on this, still got a ways to go. Okay, but after that came what we called the MIP system, which was merit-based incentive payment system. And that's going to be, it was coming, it's still under some debate, but again, the notion here is that I reimburse my providers based on how well they perform. Now, as I said in an earlier lecture, the problem here is, as a physician, I can't force a patient to take their medication. I can't force a patient to lose weight. I can't force a patient to exercise. But you're telling me part of my reimbursement is based upon that? That's a little bit of a problem. But as you can see, it's not all based on the quality of care. Okay, there's some other things as well. We also looked at what we called alternative payment models, or APMs, if you will, looking at the accountable care organizations. Bundled payments, meaning I'm going to give you X amount of dollars to take care of Y number of patients, and anything that's left, it's going to be bonus for you. If you don't take care of those patients efficiently and effectively, then you're going to eat into that and maybe be in the negative. Also looking at what we call PCMH, the patient-centered medical homes as well, which this is we're still working in this space. We got a long ways to go, but it's a good concept. Last, we talk about interoperability. Okay. And this in simplicity is just making these systems talk. Okay. If I go to, over my life, I visit 4 different hospitals across the city. In a perfect world, I should be able to go into any of those hospitals, give my name, be able to be positively identified as a patient, and see all of those records. The truth of the situation is that just doesn't happen. We still have so far to go. And here's where people say, oh, it's hard. Technology isn't there. No, the technology is there. The technology has been there. Why are we not there? Well, we have competing interests, right? So if we look at our 2 biggest players in the EHR market space, Cerner and Epic, they still don't have a mechanism to freely exchange data. Okay. Also, we have multiple payers, right? So you have the private sector, that's your insurance plans, your Aetnas, your Blue Cross and your Blue Shields, your Humana, okay? They're a class of payers. And then you also have the government sector payers, right? You have Medicare at the federal level, you have Medicaid at the state level, and then you have private payers, okay? So all of these play a role and they all have different interests and different desires. So it's kind of a carrot and stick sort of thing, okay? And then people come back and say, oh yeah, but the technology is still really not there. I'll give you this argument. Over 15 years ago, I got on an airplane. First time I had traveled international, aside from Mexico. And my employer sent me overseas to London to work. Having never done it before, I had a passport and a suitcase and a laptop. And I landed in London at Heathrow Airport and realized I had no local currency. I approached the local ATM, the Royal Bank of London, and I put in my ATM card for a local bank here in Kansas City. And I punch in my PIN number, I request cash, and it seamlessly dispenses cash to me in British currency. By the time I got a cab, made it to my hotel, logged into my laptop and checked the bank account, it had converted the currency, deducted the amount from my bank account, and I went on. Used that debit card, ATM card the entire time I was in country without any problem. So we freely exchanged information and it worked flawlessly. So we have the technology. What we have is resistance. So there's some organizations to help. Some of you might have been exposed to HL7, Health Level 7, which is really kind of like a markup language that helps us communicate between systems. FHIR is another one, Fast Healthcare Interoperability Resource, which has gained some traction, okay? Things like the Sequoia Project, the Commonwealth Health Alliance, you can read more about those in the text, but tried to go that way. Here locally, there's some as well. What's interesting is with health information exchange, there's several projects that do it at the state level. If you're like me and a resident of Kansas City, I freely move between Kansas and Missouri all the time because they're so close to each other. But we have we have KHIN, the Kansas Health Information Network, and then we have MoHealth Connect, which are completely separate entities. Well, then years ago, an entity came along called LACI, the Lewis and Clark Information Exchange, that went across state lines. Problem was, it was only looking at systems that were predominantly Cerner. So if I went to Children's Mercy, if I went to North Kansas City Hospital, if I went to any of those, or Truman Med, now called University Health, that was fine. But as soon as I stepped foot into an Epic shop, or if I went to any of the HCA hospitals or on Meditech, that information didn't freely move. So that's problematic and continues to be. Okay. As the text points out, it's not technology that's the barrier. Okay. It's health information blocking. And the text says when persons or entities knowing or unreasonably interfere. It's mostly entities. It's not really specifically persons or people, if you will. Okay. So in summary, we've come a long way. It's been 30 years. We still have a long ways to go. Healthcare continues to be lagging in terms of technology adoption. COVID has helped springboard that, but we still have a long ways to go. So let me know if you have any questions on this topic.